Hello and welcome. I'm your host, Alexis Boaz. I'm an attorney in Epstein Becker Green's healthcare and life sciences practice based out of our Washington, D.C. office. With the recent 2024 election resulting in a new Trump administration and a Republican-controlled House and Senate, everyone from policymakers and stakeholders across the industry are wondering what health policy will look like in 2025 and beyond. Today on Diagnosing Health Care, we will discuss the 2024 election results and its impacts on what we can expect in the health policy space as the second Trump administration kicks off. More specifically, we will cover how the election results might impact the healthcare policies addressed during Congress's 2024 lame duck session, what a second Trump administration may look like, and how health policy might be shaped under the Trump administration with a Republican-controlled Congress. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts.
Welcome to Diagnosing Healthcare, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare and life sciences. Brought to you by the lawyers at Epstein Becker Green.
Joining our discussion today are Ted Kennedy Jr., Leslie Norwalk, and Philo Hall. Ted is a partner in our Stamford office and has been a health policy and regulatory attorney and disability rights activist with extensive involvement and leadership across health policy on the state and federal level within government and the private sector. Leslie Norwalk is part of EBG Advisors. Leslie previously served as the acting administrator for the Centers for Medicare and Medicaid Services, or CMS, during the Bush administration. And Philo is a partner in our DC office who's held various health policy roles in government before EBG, including counselor to the Secretary of HHS and Associate Director for Health on the staff of the White House Domestic Policy Council in the Bush administration, as well as professional staff in the U.S. Senate on the Committee on Health, Education, Labor, and Pensions. Thank you all for joining us today.
Great to be here, Alexis.
Great to be part of this Diagnosing Healthcare podcast.
Hi, Alexis. Good to be a part of this conversation.
Now that we've learned the outcome of the 2024 election and have seen Republicans have swept both the presidency and Congress, everyone's looking to see what will happen with health policy now. So starting with the lame duck session, let's talk about what type of healthcare policies might actually make it through during the lame duck session and what will actually be delayed based on the election results. Philo, could you give us your thoughts on that?
Happy to, Alexis. And the best we can do is give thoughts as to what may happen, because the sort of question that you teed up about what may or may not be in an end-of-the-year legislative package in terms of healthcare is actually still up in the air following the election. So there was a healthcare package that Congress has been working on a bipartisan basis to potentially pass in December. But we've been hearing from healthcare staffers in Congress over the last few days since the election that now there's second thoughts among Republican leaders or incoming Republican leaders if they still want to pass that bill in December, or if they want to wait until next year when they're in the majority and they think they can have a better chance at getting what they want in not having to do as much bipartisan compromise. So real quick, to remind people, this concept of a lame duck healthcare legislative package is being driven by a few things, and that's a few important healthcare programs whose authorizations are expiring at the end of the year. Such things as some community health center funding, National Health Service Corps, special diabetes program, Medicare telehealth authorizations remaining from the pandemic, and something called the Hospital at Home program, again, which is a 5-year extension of a program going back to the COVID pandemic, allowing patients to receive hospital care in their homes. Now, Congress has bipartisan interest in extending these things, but then a lot of people want to attach other healthcare issues to them, and then there's a question about how to pay for them. And those questions about how to pay for it and what other issues should be a part of this have been what's slowing down negotiation. And now, in light of the new congressional majority of Republicans coming in, they're thinking maybe they may just push this to like March and try again. And I'll just briefly touch upon what some of those other policies are. There's a lot of pressure from physicians who are facing a 3% cut in their Medicare payment rates in 2025, who would like to see Congress come in and alleviate that, reverse that, or maybe phase it in over a longer period of time. AMA and a lot of physician groups, primary care and specialty, this has been their biggest issue for a year, is trying to stave off this cut that's scheduled for 2025. Also, hospitals that receive Medicaid DSH payments, disproportionate share hospital payments, are facing an $8 billion cut in 2025, and they've been lobbying for that to be blocked. And there are a few other things as well. Some of the pay-fors, though, is where the question gets very controversial. Like, what other healthcare bills would Congress pass that save money to allow them to pay for the relief of hospitals, doctors, and extending things like hospital at home? And some of the pay-fors discussed have been, let me see here, they include something called the Lower Costs, More Transparency Act. It's actually passed on a bipartisan basis in 2023 in the House, but not the Senate yet. And that package has a number of transparency provisions for PBMs, hospitals, and labs, among some other provisions, which are projected to save money for the federal government. Another possible pay for is some budget neutrality provisions, which have been discussed over the last year, which would be Congress requiring that hospital off-campus clinics be paid at the physician rate under Medicare and not at the outpatient department rate. That's continuing a policy that Congress started to phase in 2015. And hospitals would, of course, oppose that site neutrality, but Congress is looking at it as potentially saving a lot of money. And the last thing I'll mention is repealing. Congress says Republicans in Congress would like to repeal the nursing home minimum staffing regulation that the Biden administration rolled out over the last year. Repealing that would be projected to save a lot of money and could, I think, save $20 billion and pay for a lot of provisions. Democrats, of course, oppose that. They see it as a Biden administration regulation that they like to preserve. So Republicans might be thinking that if they do this next year when they have a majority of votes, it'll be easier to repeal that rule and have the savings to pay for other things. But that's sort of what has been in play. But again, what we're hearing from healthcare staff now is that they're waiting for a decision to be made as to whether this is done in December or March. So in that sense, we are just sort of waiting to see.
Great. Thank you, Philo. Turning to the post-election updates and what we've seen so far from announcements of the upcoming Trump administration, we've recently heard that the Trump administration is considering different appointees that must go through the nomination process to be confirmed, and that includes Robert Kennedy Jr. over the U.S. Department of Health and Human Services, or HHS. The Trump administration has also named a few other candidates, all of which need to go under the confirmation process before being confirmed for their position. And with these recent developments, who do we think will ultimately be on the Trump administration's healthcare team, such as over HHS, CMS, and FDA? And how will their leadership impact the direction of health policy under the Trump administration?
Alexis, I think it might make sense to point out that President-elect Trump is certainly interested in going through a recess appointment process, whereby the Senate would not be in session when these individuals are nominated and therefore could be quote unquote recess appointed. And if that were the case, it would allow the Trump administration to circumvent the normal advice and consent process that happens for Senate confirmed appointees, including, for example, Robert Kennedy Jr.'s nomination to as the Secretary of Health and Human Services. So I just want to point that out, that I'm sure people have been reading about it. Whether or not a John Thune majority leader in the Senate would let that happen is an open question, but it's certainly been the push that perhaps many of these appointments would get through without a confirmation.
And I will add on the question of who else we might see, apart from the RFK nomination, there's no other official nominations so far as of the day we're recording for HHS or FDA, CMS, or healthcare positions in the White House. But a lot of the names that are at least being discussed in trade press, that we're hearing discussed at, holiday parties or on the street around the water cooler, are at the very least a lot of names that held healthcare positions in the Trump administration before, in the first term of the Trump administration, in the White House at the healthcare agency. So that's a place to start. And then there will probably be some new names. But I think it's an opportunity to remind people that each nomination has significance. Like the nomination of Robert F. Kennedy Jr. has significance. He has an agenda on some public health and vaccine and safety issues, which Donald Trump discussed specifically when he announced the intention to nominate RFK. that will play out some way. But there's a limited amount we can take from that as to what it means for the whole healthcare agenda for the Trump administration. And so we're advising folks we have to be a little bit patient and wait to see who are the other names that get nominated to, say, FDA commissioner, CDC director, CMS director, who are some of the number 2 and 3 people at CMS, and who's staffing the White House. Because, and this is the reason why that's important, the Secretary of HHS is not president of healthcare. In reality, the healthcare agenda for the administration is not set by one person. It's not set by 5 people. It's actually a kind of arduous, debated, contentious process within an administration between the president's domestic policy staff, the president's budget staff, the president's lawyers, and then different staff, Medicare staff at the administration. So the secretary, his staff, CMS administrator. The point is that there are actually dozens of people and a lot of competing interests within any administration over what the healthcare agenda would be. And so we have to see who those people are, and we can get a sense of what the debate inside the administration may be. And then it may not be until confirmation hearings in the Senate, if they do have a confirmation hearing, as Leslie raised, where we hear people like RFK or other nominees actually start to articulate what is on deck for the Trump administration.
And Philo, just following on from your points, I would say in my experience that while the head of HHS is certainly an important position, the amount of influence that he has in this instance on any of the separate of the 6 operating divisions is a lot less than many people think. But the heads of those different divisions are far more influential in them, which is to say the components, the head of CMS has more influence over Medicare and Medicaid policy than the Secretary of HHS. Now, of course, super high level issues, not so much, but for basically the day-to-day things, the head of the agency has more ability to influence there. And the reason for that perhaps isn't surprising, because with 6 operating divisions and a lot of speaking roles, the Secretary of HHS has much to do and can't focus on a single agency all of the time. So I would point that out. The second component that could be very influential in how Health and Human Services is run is the impact of what we all anticipate being something called Schedule F, and the ability of the president and the executive branch to remove typically or heretofore civil servants that are in policy making roles that are far below the current 4,000 political appointees that the White House has control over. And with that, that can make a very big difference much farther down into an organization, although I will say it takes a long time to hire and fire people. So that might happen over the 4 years as opposed to immediately. But perhaps those civil servants that would otherwise have normally run the agency on a day-to-day basis that weren't seen as political could become political over a fairly short period of time into the administration.
I think, hi, Alexis, it's Ted Kennedy Jr. here. I think this podcast, it's currently being recorded on Friday, November 15th. So I've gotten a lot of calls and emails about the nomination of my first cousin, Bobby Kennedy, for the role of HHS secretary. And I guess since he started his campaign, I obviously, as my first cousin and for the sake of family unity, I've been very careful not to be overly critical of my cousin, but I have said in the past that I just don't think he has the skill set to run a governmental agency of this size and complexity. I mean, I have personally been a healthcare lawyer for over 30 years. I've been a student of health policy for that entire time, and I still have a lot to learn. So the idea that Bobby has a firm understanding of anything like DISH payments, FMAP, that HRSA is actually a sub-agency of HHS and what that agency does, and premium support systems for Obamacare, I think it's very unlikely that he has any kind of in-depth knowledge about that part of the healthcare policy, okay? I will say this in Bobby's favor. He has a very high IQ. He's very charismatic. He's an excellent speaker, and he's great company. There's not anyone you would want to be with if you were falconing or going on a river raft trip, or, you want an emu to live in your house. Okay. But I do think that there's many policies that he's adopted that I think are very threatening, that I'm very concerned about. Many of the people, I think, in healthcare have been concerned about what he might do from a Medicare or Medicaid perspective. But I think, and what I will say is that I think the focus of Bobby's efforts have been really in the area of food and food safety. Okay, so I'd be much more concerned if I am a manufacturer of pesticides, fungicides, and insecticides, or in the business of food, ultra processed food additives, sugar in sodas, sugary drinks, breakfast cereals, and so forth. These are the areas where I think that Bobby is really going to be focusing on, understanding that half of Americans' diet, 2/3 of children's diets are made up of ultra processed foods. So even Bernie Sanders has said that the FDA has been negligent in approving over 10,000 food additives, while the EU has approved 411. That's under the generally recognized as safe, the so-called GRAS standard. So I think that this is going to be more of the focus of Bobby, whether there's a recess appointment, whether he's fully confirmed, or whether he's just an advisor to the White House. I think we can expect to see much more emphasis on that. He has, for example, if you ever see pictures of him, he does not hold his cell phone to his head. He talks with his cell phone 4 feet away from him because he believes that electromagnetic radiation causes health problems and brain cancer and so forth. So if I'm a cell phone manufacturer, I would be more concerned than if I'm a Medicare Advantage plan or a hospital system, for example. So I just want to comment on a couple of the thoughts about the lame duck. I agree completely with what Philo and Leslie have had to say about what might not happen between now and the new Congress. I always look for things for which there is bipartisan support, such as PBM reform, the doc fix, the physician payment schedule, Medicare payment rates that impact not just doctors, but many other post-acute businesses and other types of actors within the healthcare delivery system, the telehealth authorizations, those types of things. The Republicans generally have been very outspoken with what type of reforms they'd like to see. I think Medicaid is going to be a source of pay-fors, things like premium supports for the millions of Americans who currently get their health care through the exchanges, with the help of the federal government supporting those premiums. I think that it's no surprise to see that those kinds of supports, that kind of governmental spending, is going to disappear. It's probably not going to be reauthorized next year. So what is the impact of that? What is the impact of the millions of people who are currently obtaining premium support going to have in those states? And of course, when they go see the doctor or hospitals, I don't think it's good news, for example, for rural hospitals who will now see people showing up at their emergency rooms who may currently have Medicaid, which of course doesn't fully cover the cost of the visit, but at least it offsets some of those. It's not a total loss for providing that care as it would be what I think will probably be in another year or so. I think it's going to be an interesting time. Again, I think my cousin Bobby has been very outspoken. The Washington Post on Friday, the 15th, has basically detailed a laundry list of the things, of statements that Bobby has said in the past. I think he's, again, going to focus on the so-called regulatory capture, questioning a lot of the way decisions are made, and we'll see more to come on that. But whether or not Bobby is actually confirmed or has a recess appointment, I think it's fair to say that he's going to have a very large influence in the area of public health, but specifically with regard to food, as I just said, as opposed to, I think, the way that healthcare is organized, delivered, and paid for.
Sounds like that means the deputy secretary nomination, the CMS nomination are going to be very important as well. All those issues have to be led by someone at the Department of Health and Human Services eventually.
What do you think Bobby's position how Bobby's position on vaccines will have an impact on what happens at the department.
Look, I'm not saying anything that isn't already widely, understood, that he is, one of the leading anti-vaccine evangelists. And he holds these beliefs with religious type fervor and passion. So no matter how much evidence that you may present and has been presented, talking about the studies that he relies upon that have been discredited, it's very hard to refute this narrative and his belief system. I think that the vaccine mandate, I think that for example, the market reaction yesterday about leading vaccine makers' share prices plummeted at the news of the announcement. I think that may be a little bit of an overreaction because I do think we need vaccines. I think even the staunchest Republican public health advocates will agree to that. So I think you're just going to see a much more scrutiny on the schedule of vaccines, et cetera. But I don't think you're going to see an elimination of vaccines in the United States of America.
But I don't know if the mandates are more federal or local, but you're thinking that if there were federal mandates, that they would be somehow diminished.
What's hard for me to say, Leslie, in my view, is that the COVID vaccine development was nothing short of a miracle. Okay, that's my own personal viewpoint. I think that Anthony Fauci is a national treasure. Now, those are not the same ideas that are held by many people in the current Republican Party. But so I just think you're going to see an emphasis on the food and disclosure and the so-called regulatory capture. If you look and read about Bobby's speeches and writings, he talks about biostitutes. These are the scientists who misrepresent scientific research for the benefit of commercial interests and for themselves. He's fed into the whole idea that the regulatory system, whether it's the Environmental Protection Agency, these agencies that have told us that Agent Orange was fine, and then we learn decades later that there's many public health impacts of a lot of these chemicals and pesticides, fungicides, insecticides that are currently consumed by the U.S. Population that may need an additional scrutiny, I guess you could say.
I wonder if that carries over generally into drug development, even beyond vaccine development. I haven't read anything specifically if his focus is across the entire regulatory system, or as you noted, more specifically toward food and maybe vaccines. But you wonder if there might not be additional scrutiny across the board at FDA.
I think that there could be very well, with the incoming Republican administration, you may see a loosening of standards for innovator companies who are bringing their products to market, who are now contend with a very onerous process at FDA. I think you may see the opposite effect. I'm not saying that for sure. This is just a guess, but I don't think you can take those positions with regard to vaccines and say the entire innovator biotech life sciences economy is under threat, because I think in many ways you may actually see an acceleration and a loosening of standards to approval. I don't know whether you or Philo agree with that.
Yeah, that's an excellent point, Ted, because we have this question that we have to see how those views of RFK match up against what has been the Republican and Trump administration priorities in the past on the innovator pipeline from development to Medicare coverage, for example. Let's recall that the Trump administration implemented a rule, which was subsequently withdrawn by the Biden administration, for breakthrough devices, medical devices that had breakthrough status that would get automatic Medicare coverage. And they were experimenting with other proposals under Medicare that if drugs or devices were covered by private commercial plans, they would be automatically covered by Medicare. That was an idea that was out there as well. As you say, then there are concepts also about the concepts not just from the Trump administration that were shown during his first term, but widely held in Congress, that the FDA is a bottleneck to life-saving therapies right now. I think we've heard from some Republican staff and members of Congress who look forward to a new majority to make sure that the FDA and also CMS using its authority under the Inflation Reduction Act to quote unquote negotiate drug prices. They want to make sure that that does not pose a barrier to innovation or drug supply. I guess it's just to agree with you, Ted, that there's sort of two themes which seem sort of in tension. We may see how those play out when someone nominated for the Trump administration is in a Senate confirmation hearing, or as we see more people with backgrounds or maybe alternative views who start being nominated to some of these positions.
Totally agree about the tension between those two policies. It'll be very interesting to see how that plays out. And I agree with your overall assessment, Ted, and probably yours too, Philo, that at the end of the day, I expect that there will be a loosening, but perhaps that's very targeted as to where it occurs versus where it's strengthened.
Great. Thank you guys for that. Now that we've talked about some of the industries that might be losers under the Trump administration, let's talk about some others that might be under threat or might have some advantages. We can start with Medicare. Philo, do you have any thoughts on that?
Yes, I'd like to start with Medicare Advantage. Now, I think we can, over the next few weeks and months, talk about headwinds and pressures for providers in the fee-for-service space, particularly with maybe increasing numbers of the uninsured, as Ted mentioned earlier, with expiring enhanced premium subsidies on the exchanges. Those are some headwinds. But I think things will definitely should be better for the MA sector, for the MA plan specifically. One, there's been a lot of industry concern with the trends in federal payments to MA plans in the Biden administration. And we have a Trump administration that has been very explicitly clear about wanting to increase Medicare Advantage relative to Medicare fee-for-service enrollment. People, if they have a moment, they can Google the 2019 Trump executive order on Medicare, and the principles of his administration on Medicare were laid out there. And that's a good thing to refer to. And it's something that's pretty much shared across the Republican Party, which is to see Medicare Advantage as superior to fee-for-service and to promote enrollment, to make the options more attractive in Medicare Advantage, and to make enrollment there more attractive. There's a statutory idea, there's an idea in legislation from some Republicans that Medicare Advantage be the default enrollment for beneficiaries when they turn 65, and then you have to opt out of it if you don't want to be in Medicare Advantage. I don't know if that will present itself in the next few years, but I do think the sector can expect or hope for more favorable rates in the benchmark process on an annual basis, at the very least.
Yeah, and Philo, I think the advantages to the MA plans go beyond just the MA plans. Lately, there has been a decline in the supplemental benefits that are offered to MA plan enrollees, in large part because of the reduction in payments. So if the payments go back up, I see supplemental benefits again increasing. Agents and brokers who provide help for Medicare beneficiaries to enroll in these sorts of plans and other types of plans, I think they will also be more supported by a change in administration. So it's not just the plans themselves, but I think there are those who provide things adjacent to the plans that will be helped by the change in administration. I even read beyond something as stark as default enrollment for all Medicare beneficiaries to be put into a Medicare Advantage plan as opposed to fee-for-service. I also read that there might even be a move away from the standalone drug plan, so that if you wanted to get a drug benefit, you would need to join a Medicare Advantage plan. I mean, that's pretty controversial. We'll see if that makes any headway. But overall, I imagine a great push toward Medicare Advantage in a way that we would not have seen had Harris been elected. And in large part because we already have over 50% of all Medicare enrollees in Medicare Advantage plans. So in a way, because Medicare Advantage is focused, reimbursement is focused on fee-for-service, a change in how we pay Medicare Advantage, perhaps delinking the two, is also a possibility. So I think you've got a lot of really big policy choices coming down the pike over the next year or so that haven't really been on the radar for the last several years, but are now coming to the fore.
And I want to just piggyback on that, Leslie. I agree 100%, but there's also, we should temper it a little bit or just make clear that the administration and the Republicans are explicitly pro-MA program, but that doesn't mean that they are pro-MA plan. And so I think days will be better for the MA industry, but not across the board on everything. The Trump administration, at least if we are to follow their lead from their first term, there's still plenty of, I think, a continuation of the Biden administration's skepticism of some plan coding practices and the need for more oversight or guidance on not having coding practices get to a level that they believe is beyond what is necessary or not supported by the medical record. In fact, we're hearing on the day we're recording this that CMS is sending out notices to MA plans of whether or not they're going to be subject to a RADV audit in the coming year. And that's using regulatory authority that was set up in the Trump administration in their first term. And one other sort of cloud, not a silver lining, but a cloud in this is we expect the Trump administration, maybe unlike the Biden administration, to, as Leslie said, really embrace the importance and the value of a robust supplemental benefit package in MA. And that's great for the plans, that's great for the enrollees. But more and more providers and physicians are delivering care through MA under at-risk contracts, and they're often being asked to carry the risk for the supplemental benefits, including cash cards. And that is a source of a lot of pressure for a lot of value-based providers. And as I was looking over that Trump 2019 Medicare executive order that I just mentioned, I was reminded that the Trump administration at that time was saying that cash cards, cash rebates, cash benefits under Medicare Advantage, they view as a means for the beneficiaries to share in the savings of Medicare Advantage. That can be bad news for at-risk providers who maybe will then see more of the premium that they're at risk for being outside of direct medical care. As Leslie said, I think there's a lot of interesting policy that's raised and will be coming down the pike with this.
I guess my only final comment on this subject would be I agree with Philo and Leslie that I think Medicare Advantage would be the preferred way to administer Medicare in the Republican administration. I think the regulatory enforcement, that is, that a lot of providers who undergo a lot of audits and so forth, I think that that'll be less regulation or easier to comply with perhaps the regulatory state. I also, regarding supplemental benefits, whether it's the cash cards or the rides to the doctor, even air conditioners, food, that kind of thing, many of these supplemental benefits are also incorporated in Medicaid plans. And I sort of see pressure, I guess you could say, as Medicaid gets cut, these efforts under the Biden administration to address sort of the social determinants of health by providing these ancillary or supplemental benefits, I believe may come under pressure as people question the value of some of these benefits.
That's interesting, Ted. There was a perception among some that in the Biden administration, it embraced and promoted the use of supplemental benefits under Medicaid to address social determinants of health, but they were simultaneously criticizing the growth of those benefits to do the same thing under Medicare Advantage. And perhaps we're just going to see a reverse of those positions in the next 4 years.
Great. Thank you, Philo, Ted, and Leslie. This has been a great discussion, and you guys have covered a lot of ground here. So thank you for taking the time to participate in today's discussion, and thank you to all of our listeners. I'm your host, Alexis Boaz. If you like what you've heard today, please don't forget to subscribe. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare and life sciences, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. This podcast is presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of legal services to be performed is greater than the quality of legal services performed by other lawyers.